My topic is disorder of fluid and electrolytes and maintenance intravenous fluid. Definition: the administration of intravenous fluid is essential in acute care, although there is no consequence on the most appropriate rate for administration and composition. Because the evidence is limited, recommendations of this topic are based on opinion. Administration of hypotonic intravenous fluid for maintenance in both children and adults is common. This is associated with a high incidence for acute hyponatremia and with iotroic death or permanent neurologic deterioration related to hyponatremic encephalopathy. Medicine application: fluid resuscitation. If patients require fluid resuscitation, use crystalloid containing like 130 and 154 mol for liter sodium with a bolus for 500 ml in less than 50 minutes, based in moderate quality evidence for random clinical trials and cost-efficient evidence. Don't employ tetramethaine for fluid resuscitation based of evidence for cost-efficient and concentrate 4 and 5% human albumin solution for fluid resuscitation only for patients with severe sepsis.
IV fluid resuscitation is indicated when a patient is showing signs of clinical shock. Using your ABCDE approach, by the time you've come to see, you should have a good idea of whether the patient is in shock or not. You may see signs of hypertension, tachycardia, cool peripheries, a long capillary refill time, or a high respiratory rate. You then want to initiate treatment when you suspect clinical shock. You want to give 250 ml or 500 ml bolus of IV crystalloid given over 15 minutes. The crystalloid solution can either be Hartmann's solution or 0.9% normal saline, and it's good practice to give 250 ml if the patient has known or suspected heart or renal failure. After this, you want to reassess the patient again using ABCDE. Their signs of clinical shock may have improved at this point. However, if there's no change, continue with further boluses of IV crystalloid. If the patient has now received 4 rounds of bolus fluid and there's still no improvement, now it's time to get help. The patient needs ICU advice and treatment to further support their recovery.
In flight medical emergency, did not mention that acute allergic reaction may occur on airplanes, probably triggered by food, especially peanut, commonly served on flight, a drug, or in rare case, an insect bite or sitting. Food allergic among children increased by approximately 50% between 1996 7 and 2011. This first-line treatment for anaphylactic, a severe and often life-threatening reaction in prompt administration for heparin and a hospital visit because the need for treatment is often immediately, especially in persons with hypotension or airway compromise, and that may occur before transferring to hospital. Many states have passed law to ensure that epinephrine is available in school and other public buildings. Pros and cons. Pros: all patients who continue to receive fluid should be monitored at regular intervals. This is initially include their reassessment for the patient's water status, laboratory values like urea, creatinine, and electrolytes, and water balance sheet low with twice weekly with high determination. If patients are moved another location, receive their hydration and fluid management plan of arrival in new setting. Considered indication let fluid example 20 or 25 ml per day for patients who are more LD for frail or having renal or cardiac insufficiency. Healthcare professionals should be trained and educated on the topic and be competent in recognizing, assessing, and preventing the consequences for fluid treatment, including pulmonary edema, peripheral edema, hypovolemia, and shock. Cons. Before treatment, hyponatremia, serum osmolality, and volume status should be determined to guide therapy. Hyponatremia treatment requires close monitoring to ensure maximum correction. After resuscitation is complete, fluid administration should be decreased to sensitive and insensitive lows and maintain appropriate fluid balance. Critically, patients are often hypermetabolic, necessitating increased efforts. Recommend. Insius applied are in Ecuador. I describe of a study what are carried out by applying and survey to each for the attending physical or anesthesiology service working in 4-level hospital in city of Quito. The data analysis were carried out throughout the application for the APE program. The equality variables were expressed in simple frequency and percentage. All data were analyzed with a 95% confidence interval. The results 67% for responsible continue to use the original formula for holidays and SEGAR for the compensation for prepared fasting and calculate for managing fluid. 30% of them mentioned have some training in pediatric anesthesia. 18% for responsible indicate not having protocols on periodic fluid therapy for patients in their service.
Normal saline is a commonly used isotonic intravenous crystalloid fluid. Although it was created to approximate the same osmolarity as human plasma, normal saline contains higher sodium and chloride concentrations than plasma, and its infusion can lead to hyperchloremic metabolic acidosis and kidney injury. Balanced crystalloid solutions, such as lactated ringers and plasma light A, have more physiologic electrolyte concentrations, and thus may have less negative impact on acutely ill patients. In the single-center pragmatic unblinded SALT-ED trial, investigators tested whether the composition of crystalloids affected outcomes in non-critically ill patients. Over 16 months, the trial enrolled 13,347 adults who received 500 milliliters or more of isotonic crystalloids in the emergency department and were subsequently hospitalized, but not in an ICU. In alternate months, participants were assigned to receive either balanced crystalloids or saline. The median crystalloid volume received was 1,079 milliliters, and 88.3% of patients received only the assigned fluid. The primary outcome of hospital-free days, defined as days alive after discharge before day 28, was the same in the balanced crystalloids group and the saline group, 25 days versus 25 days. Patients in the balanced crystalloids group had a lower incidence of the secondary outcome of major adverse kidney events within 30 days, which was a composite of death, renal replacement therapy, and persistent renal dysfunction, 4.7% versus 5.6%. A concurrent study performed among critically ill patients also showed a reduction in major adverse kidney events within 30 days, 14.3% with balanced crystalloids versus 15.4% with saline. The authors conclude that among non-critically ill adults, balanced crystalloids and saline resulted in no difference in hospital-free days.
Conclusion. There are no protocols on the management for perioperative fluid therapy for patients in the anesthesia service for the hospital institute, so their implementation is required based on the current evidence. There is minimal tendency for like 4% to the use hypotonic solutions such as 2.5% dextrose in solution and saline 0.55% for the management for perioperative fluid therapy in the population, which have been shown to be related to the incidence for perioperative iatrogenic hyponatremia.
This is a short presentation explaining how the NICE guidance on intravenous fluid therapy will be implemented at the Great North Children's Hospital. We're going to first look at complications of inappropriate or unmonitored IV fluid. We're going to look how the guidelines try and reduce these complications. And we're going to explore how we plan to implement the guidelines. When poorly in hospital, children's electrolyte balance and fluid balance can be affected. And problems with abnormal electrolytes or problems with fluid overload and hypovolemia can be made worse by inappropriate or unmonitored IV fluids. Electrolytes of particular importance are potassium and sodium. There have been recent patient safety alerts because rapid changes in sodium have resulted in neurological injury and death in children, and inappropriate intravenous fluid therapy has contributed to these adverse events. The NICE guidelines state that for maintenance fluid, initially isotonic fluids, which in electrolyte composition most closely resemble normal human blood, should be used. Potassium should also be added routinely unless there's a contraindication, like renal failure. Use and ease should be monitored daily to guide fluid prescribing. However, for lots of reasons, children might need alternative fluid prescriptions. If this is the case, decisions will be led by the responsible medical team. Unless deemed clinically inappropriate, weight should be monitored daily and any changes noted. Fluid balance charts should be updated with running totals and also daily totals and overall fluid balance. As well as raising awareness through this video, we will also be adapting fluid charts to try and help keep within these guidelines. The new IV fluid prescription charts now contain an area where maintenance doses can be totaled, where alternative fluid plans can be justified if necessary, as well as the normal space to write a prescription. If rates of fluid administration or type of fluid is not in keeping with the guideline, for example fluids with different saline or potassium concentrations are used, the justification can be now clearly documented on these charts. In addition, fluid balance charts now have an extra section where weight can be recorded and compared to previous days to look for any differences or fluctuations in weight, and prompts to calculate daily fluid balance have been made clearer. In summary, 0.9% saline fluids should be first line, and fluid prescription charts should explain why this isn't the case in certain situations. Please ensure that weights and fluid balance totals are kept up to date and checked regularly. Applying the guidelines by using these interventions should help ensure the safety of children on intravenous fluid therapy at this hospital. Thanks very much for listening.
Thank you.